I'm Naoki Wada from Asahikawa Medical University in Japan. My title is Risk Factors for Failed Dutasteride Add-on Treatment to Alpha-adrenergic Antagonist for Patients with Lower Urinary Tract Symptoms. I have nothing to disclose. The dutasteride is the only 5-alpha reductase inhibitor approved in Japan. Dutasteride has widely been used to keep improving lower urinary tract symptoms and to reduce the relative risk for urinary retention or surgery for benign prostatic enlargement. According to the nationwide survey in Japan, since the introduction of dutasteride in 2009, the surgical procedure for BPE have decreased. However, dutasteride treatment is not effective for all patients. We try to identify the clinical parameters resulting in the failure of dutasteride add-on treatment to alpha blockers. We previously reported the efficacy of dutasteride add-on treatment to alpha blocker prospectively from December 2009 to November 2011. This time, we retrospectively surveyed the patient cohort who had been enrolled in this study. Inclusion criteria of that study were over 30 milliliter of prostate volume and 8 or more of IPSS or 3 or more of IPSS-QOL. Treatment failure was defined as receiving surgery for BPE or requiring intermittent catheterization or permanent bladder catheter for urinary retention or huge post-voidal residual urine. Clinical parameters before dutasteride add-on treatment, including age, symptom score, PV, intravesical prostatic protrusion, and urodynamic parameters were compared between the successful and failed group. Of 92 patients, 23 were categorized into treatment failure group at 7 to 109 months after dutasteride add-on treatment. In the failed group, the patient's age was younger, prostatic volume was larger, boiling efficiency was lower, and the BOO index was higher before dutasteride add-on treatment. Kaplan-Meier curve indicates that the non-failure rate at 3 years was 79%. Cox proportional hazard model shows there is statistically significant association between IPP and dutasteride treatment failure with 9.9 of hazard ratio. ROC analysis shows the best cutoff value of IPP was 13 mm. Again, Kaplan-Meier curve for non-failure rate by IPP indicates that less than 13 mm of IPP is significantly better than 13 mm or greater of IPP. So our results are consistent with some previous studies. High IPP influences the efficacy of dutasteride therapy, and high IPP is associated with severe obstruction. Transurethral surgery of prostate can provide good long-term outcome if only obstructed. Patients with 13 mm or greater of IPP are likely to have obstruction and likely to be refractory to dutasteride, and these patients should be recommended early surgery. Retrospective study and small sample size are limitations, and we didn't evaluate the reason for surgery. So in conclusion, 13 mm or greater of IPP is risk factor resulting in the failed outcome of dutasteride add-on treatment with alpha blockers. Thank you.